Good afternoon, everyone. Welcome. My name is Emily Castillo, and I'm the Director of Programs for Insure the Uninsured Project, or as we're more commonly known, ITUP. We're thrilled to be partnering today with Blue Path Health, Connecting for Better Health, and the California Association of Area Agencies on Aging, also known as C4A, on today's workshop, Data Sharing to Support Older Adults. For those of you who are not familiar with ITUP, and apologies to those of you who are, we are a 26-year-old health policy nonprofit and convener with a mission to promote innovative and workable policy solutions that expand healthcare access and improve the health of all Californians. We have three key policy focus areas: coverage and access, in keeping with our original mission of ensuring the uninsured, delivery system transformation, and the future of health and the health system. We implement our mission through policy-focused research and broad-based stakeholder engagement. A large part of that engagement takes place during our 10 annual regional listening sessions, where we travel virtually these days around the state, all the way up from Humboldt down to Riverside and everywhere in between, where we gather local healthcare and community-based partners to connect around how state-level policy impacts their communities. And over the last 2 years, we brought folks together on CalAIM implementation, specifically focused on building partnerships between community-based organizations and the healthcare delivery system to make the goals of CalAIM meaningful for those communities. In these convenings, as we discussed actionable ways to address challenges and build successful partnerships to ensure the success of the CalAIM goals, we heard overwhelmingly that a key barrier to addressing social determinants of health is hindered by providers' ability to exchange information between and across the various health and social systems. In other words, it was made very clear to us that the collection and integration of patient data across sectors in both clinical and non-clinical settings is vital to achieving interoperability between various health and social systems to address the unmet needs of all Californians, including our state's rapidly growing older adult population. So at the same time, through ITUP's work in the aging policy space, it was also made clear to us and our partners within that space that despite our shared goal to achieve an equitable health system for all Californians, there was still a broad disconnect between the healthcare policy and aging policy communities. I like to use this analogy. While we were all rowing in the same direction, we weren't rowing yet together. And as you all know, we are stronger together. So one of the reasons I'm particularly excited for this work group is because it is bringing together those historically siloed systems of stakeholders, healthcare delivery, data exchange, and aging, to discuss the common opportunities for collaboration. I think conversations like this one will be vital to ensuring success as we embark on incredibly ambitious statewide initiatives like CalAIM and the creation of the data exchange framework, which my colleagues will discuss in more depth later on in the program. So with that, I'll wrap up my comments so we can get to the more fun part of the workshop and pass the mic to my colleague, Michael Costa. He is the Executive Director of the California Association for Area Agencies on Aging. Ooh, that's a mouthful. He has over 30 years experience developing and implementing products, programs, and policies implementing and impacting older adults and other vulnerable populations. His experience spans from business and strategic planning, analysis, implementation, and health policy and reimbursement. He's worked with the area agencies on aging, local community benefit organizations, and state trade associations, helping them understand and respond to opportunities in an evolving market and regulatory environment. Thank you so much for sharing this space with us today, Michael. The floor is yours.
Great. Well, thank you, Amelia, for the my background. It sounds so good. I'm going to use you as my my public relations person from here on out, I think. So it's a pleasure being here today. And I found myself, I've been at C4A, which is the short way of saying that very long-term designation for my association. I've been there about 1.5 years now. And one of the things I find I need to do is just sort of tell everyone what a AAA is, because it's not immediately clear. So this is the startup slide for many presentations. I believe that AAAs are key to integrated older adult services in California. And basically, a AAA is an organization that provides services allowing older adults to live at home and in their communities for as long as possible. This is the prime directive for area agencies on aging, and this extends back to their founding as an amendment to the Older Americans Act in 1973. And it underlies the Older Americans Act, the basic prime directive, to an act that was founded as a Great Society program in 1965. We know AAAs as departments of aging or as local nonprofits such as Sourcewise in Santa Clara County. There are 33 of them in California, and they cover all 58 counties. So the range of services is pretty great. And a primary AAA service, going back to the beginning, is information and referral to help folks find local services. That AAAs coordinate and direct services and provide services directly, or they contract out with services from community providers such as Meals on Wheels, transportation companies, and home modification contractors. Since their authorization, AAA provider networks have grown across the state and are positioned to contract with healthcare payers and providers to build an integrated service delivery system for older adults. Now, mind you, this network, as Amelia mentioned, actually has been many, many decades in the making, and it has really grown up and developed in parallel to the healthcare network, but has not really talked much. There hasn't been a lot of crosstalk. So now we're in a position now where we're all beginning to see the value of integrating social and healthcare services for older adults. And crucial to that is having an effective data sharing system. So I'm excited by this workshop because we really are going to talk through how we do that. And because it is, again, a crucial part of integrating services for older adults. So now I will pass it on. I think we're ready to start. Timmy?
Hi, thank you. Yes, thank you, Michael. And thank you so much, Emily, for kicking us off. Hi, everyone. I'm Timmy Leslie, and I am with Blue Path Health. We're a consulting firm in the San Francisco Bay Area, and we also lead Connecting for Better Health. And this workshop is part of a series that we are just so proud to be able to help support. And just to give you all an update, if you're not familiar with Connecting for Better Health, we're a coalition in California that aims to advance health data sharing to support both the provider and the patient. We are really active in education. We're constantly looking for those bright ideas, new research, to be able to pull in and educate our stakeholders on what's the possible, the art of the possible for data sharing, as well as to give our policy leaders support to be able to keep moving forward and be able to advance not only policy around data sharing, but also as a key priority area of ours is also funding, and looking at how can we be able to braid and gather funds to the best extent possible so that we can make a sustained investment in data sharing across the state. We also are, we hold meetings every other week where we are able to relay updates on the work that's happening in the state around data sharing. And we are also tracking events and pulling really great conversations like today together so that I think we can all be rowing in that same boat, as Emily mentioned. I really welcome you to check out the website. We'll put the link in the chat and also join us. We would welcome your insight and engagement as we move forward. If you can go to the next slide, please. So we have a really great agenda today. Working on this virtual workshop, if you will. I think all of us would love to be in the same room with whiteboards all around, being able to make sure that we're sharing our sticky notes, but we're going to do the best we can today in this virtual Zoom world. And I am really excited to be gathered to have such a great group ready to go. The way that we would like to be able to step through today is to be able to give you all some, some key common understanding So we have some speakers that will be coming on board from the state as well as at a county level that is implementing at AAA in Ventura that is implementing this as we speak. And then we're going to be able to bring on a whole group that will gather and discuss for a good hour discussion. And I really would hope that we can use this space to engage with both the participants as well as the audience. If we could please a little bit of housekeeping. We have the Q&A on board here. Feel free to type in your questions as you think about them. We will all try to, excuse me, engage and answer those questions real time, or I'll try to pull them in and direct them to the speakers. We can also use our chat to be able to share information, introduce yourselves. Again, we're going to really try to make this as interactive as possible. Let's go to the next slide. So I want to thank Blue Shield of California for sponsoring today's event. We would not have been able to do it without you. So thank you again, Blue Shield, for your support for this discussion. And in addition, for the discussion today, we will work to publish a summary that we can use to be able to guide future discussions. Go to the next slide. So I'm going to spend just a few minutes here to walk everyone through the data sharing framework that is the work that the state has the work that the state started 2 years ago, and where are we today? Unlike several other states that have moved forward with a statewide health information exchange or a state-led HIE or data utility, California is moving a slightly different direction. And instead, we have a data sharing framework that includes data sharing agreement. And part of that agreement will also include several of policies and procedures. Think of it as the guardrails and the traffic lights and how we're going to be able to move through the advancement of data sharing together. I think what's really interesting and unique about this approach is it started with an advisory group that spanned multiple different stakeholders, as you can see here. It centered the patient and the provider to ensure that the rules of the road really emphasized the need to be able to make it very patient-centered and provider-centered. And I also just, when you step back and look at the guiding principles, it should galvanize all of us to move in the right direction or the same direction. And it leads with advancing health equity. So when you think about equity and advancing access, we do not want to leave populations behind. We want to make sure that all stakeholders have the same access to information. And again, putting both the patient and the provider in the center. So if you are not familiar with the data sharing framework, I think we will put links in the chat. Definitely familiarize yourself with it. There's it's really terrific work. And I think even though the California seems to be behind several states in the ability to be able to share data, health data, we are really hopeful that the data sharing framework will hopefully help to leapfrog a bit and get us down that path a lot faster. So let's go to the next slide. So this is just a moment on the data sharing agreement itself. Over the last year, the data framework or data sharing framework advisory group spent a lot of time and effort to be able to come up with a data sharing agreement. Again, this is something that all stakeholders will be asked to sign, and it really gives you more detailed on how you're going to, be an actor and be a steward of the health data and be part of this ecosystem that will, again, leave no one behind. So even though there are required recipients or required signatories, the data sharing agreement is there for not only those that are required and really covered by HIPAA, but also the social service organizations And I think that's the opportunity of why we're here today, to what we were calling at the beginning of planning these workshops. How do we stress test this data sharing agreement to make sure that it actually works for community-based organizations, our AAAs, and those organizations that the AAAs serve? And I think that's what we really need to focus on today, is where there might be some gaps or opportunities for the data sharing agreement to be, to be workable and usable as we move forward. The next slide. So where are we? We have the data sharing framework, we have data sharing agreement, but the work is, there's so much more work to be done. And the state has, in addition to having the an advisory group that will lead around the data sharing agreement, they have an implementation advisory group as well that's really going to be tackling some of these more detailed issues, in addition to a policy and procedure work group. Again, all of these are open to the public, and there are many of us in part of the Connecting for Better Health work. We follow this work and will relay the advancements and the progress as they are made. But this is where we'll be looking over the next 6 to 12 months, is what is the governance? What type of governments are we going to stand up in order to ensure that there's some bit of enforcement on the data sharing agreement? Who, of course, is required to participate and be a signatory? Who will be encouraged? And is there a need for additional legislation? These are all the types of questions and areas that will be looked at in more detail. And also, I think just important to this conversation today is how will regional and community health information exchanges participate in the data sharing framework? And will there be, and I think we are going down this road right now, of a qualification process for HIE, so that we're really making sure that we have similar features and functionality that the HIEs can contribute to this work. And we'll dive down into that in more detail today too. And next slide. So that's just some really high level grounding. There's some great research and references that we'll be putting in the chat to answer any of your questions. And of course, we'll be looking at, if you have more detailed questions, the experts are here and can relay that work for you or to you real time. So I'm going to hand it off right now to the California Department of Aging, and Mark Beckley, if you could come on your video. We're joined by Mark Beckley, who's the Chief Deputy Director, and Andrea Hoffman, who's the Chief Information Officer. We welcome, and I know that you're going to be walking through your strategy, or walking us through your strategy for data sharing with the work that you do. So thank you so much.
Great. Thank you so much, Timmy. And thank you to all the partners who are holding this workshop today for inviting us. We really are pleased to have the opportunity to talk about our data governance and data strategy going forward with all of you. I'm just going to provide some high-level remarks, and then our Chief Information Officer, Andrea Hoffman, will be walking through a detailed presentation of what our data strategy looks like going forward. I'd like to start off by saying that one of the goals of the California Department of Aging, since we've implemented our master plan for aging in January of 2021, is to collect as much data as we can about older adults and individuals with disabilities, really with an eye to looking for and assessing gaps that exist in the system that need to be addressed, and taking advantage of opportunities that may exist. So leveraging partnerships, other relationships, so that we can really construct a seamless system of services for older adults and individuals with disabilities. And that includes, key partnerships and data exchanges with health organizations, with other social services organizations, so that we can really create this truly holistic, person-centered view of data, and make sure that the services that we offer are offered in a very seamless way to our participants. We've been doing great work with the Master Plan of Aging We've collected great data sets across all of our key areas of our master plan, including housing, health, family caregiving, inclusion, and affordable aging. What Andrea will be walking you through is what our data strategy looks like in creating a central data warehouse to collect all of this data, and then how we plan on partnering with our different partners and agencies to really make the best use of this data. So with that, I'm going to hand it off to Andrea, and she'll be walking through our presentation today.
All right, could we go to the next slide? Thank you. So the main takeaway we want to get to today is for all of us to develop a common understanding of where CDA efforts are today and how we have to move forward to develop a very inclusive enterprise data strategy. And we mentioned earlier rowing in the same boat. So how, from a data perspective, can we all row in the same boat from at least from a state perspective today? Next slide. Several topics to cover. It seems like a lot. I think I could skip through a lot of the data exchange framework. It was covered quite a bit. So we'll talk about some guiding principles, where we are in establishing a data program and really setting that foundation to be able to have the capabilities to share and exchange data at the state level. And then our conceptual approach. What does this look like? How can this be done? We have a statewide enterprise system called CHARM. We'll briefly talk about a couple key points with the data exchange framework and some takeaways for the AAAs and ADRCs and other community partners, as well as our timeline for 2023 and a little bit on the data dashboard. Next. So the data guiding principles really align with what CalHHS data exchange framework principles are, but we want to just articulate a few little nuances here. We want to embed data integrity, accessibility, and reliability in all our data related efforts, and even initiatives that don't necessarily have data. We want to be thinking always about integrity, accessibility, and reliability, because downstream that translates into reliable, consistent reporting, data sharing, etc. From a security perspective, we want to make sure our data is in compliance with state and federal rules. We're maintaining confidentiality and privacy and meeting all the requirements and laws related to that as well. And very important is the equity focus and keeping that equity focus lens to make sure we're advancing the MPA goals and initiatives with equity and inclusion at the top of mind, and embedding that into our approach wherever we can when it comes to data. And partnerships, Mark mentioned it, and we definitely want to row in the same boat with all of you. It's really, really critical to get where we want to be in terms of a data-driven organization to form and nurture those partnerships. And it's going to take a lot of work, as has been mentioned before, to get there. And so the dependency on really strong partnerships, and the state is looking forward to working with all of you. Lastly, growing smart is important. We're at a pivotal point on the state side to grow our program in a smart way so that we establish a solid foundation from a business and a technology perspective to support the data sharing and exchanging that we all want. So these are just some guiding principles to enhance what was mentioned related to CalHHS. And we can go to the next slide. So a foundational component for us is building an internal data program. We need to establish a cohesive program to build the capabilities necessary and the capacity, both from a technology and a resources standpoint, in order for us to share, report, and exchange data with all of you. So to make the tangible progress that we want to with some of our key initiatives and some of the data exchange framework concepts, we really and to support the AAAs, it's vital for CDA to look inward a bit and establish the foundational structure to support these longer range goals. So from a foundational standpoint, really number one is getting a data team and getting that data team between the business and IT to work from the same set of principles and guidelines. We have some of the business side of the data team established, but we are looking to recruit a chief data officer. And one of the exciting things from this is to have the alignment at the state level between the business, the IT, and we recently hired an enterprise architect and align the technology solutions with the business strategies when it comes to data. So this is really, really exciting for us. Secondly, once we have this team established, this was also mentioned, data governance committee, where we want to enhance our partnership with you, the AAAs, ADRCs, to come together and really make key decisions about data, develop the key processes and methodologies for sharing and exchanging data, prioritizing data needs, and really establishing the framework at the state level to exchange data in a meaningful way, and having everyone row in the same boat is really, really important, especially as we build out technology. Next, we want to develop standard data processes and guidance. That will really come out of the data governance committee with input from the AAAs and ADRCs. It's really important to do what we want to do with data, to be operating from the same methodology, standards, processes, to make the most out of data. And that will lead us to developing an enterprise view of data. This is another foundational element. We'll talk in a later slide about how we get there, but an enterprise view of data from a business perspective so that we can later use that to develop the technical capabilities, such as a data warehouse, single source of the truth data repository. So that is it on this slide. Next. Okay, this one is not scary, I promise. It looks a little intimidating, but I think visually it can help substantiate some of what we just talked about. So establishing it, you see in the center of the screen here, is an enterprise data warehouse. That's our repository of data. This has not been developed. This is where we want to go. And this central repository will collect data from the AAAs, ADRCs, and other programs to be defined, and have a single source of the truth repository. From there, we can serve out the data to, say, our statewide customer relationship management system, which we call CHARM. I have a slide about that. And also feed data and share data with other systems to be defined. But the critical part of that is having a common framework to share the data, where I mentioned earlier, common data processes, common framework. In this CDA external data sharing framework, we're definitely going to look at the data exchange framework by Cal HHS, but we'll probably have to enhance it for our needs in order to do what we want to do with data in the state with the aging program. So having the central warehouse, having data collected and migrated from different entities as listed here and other future programs, and being able to share that data out in a consistent, reliable manner, following a common framework. We can also use this approach for external reporting, agency data sharing. The general concept will allow us to do that. As we get into design and implementation, this may have to be adjusted, but at least where the state is now in envisioning where we want to go with data, this pretty much represents that. But to be successful, to guide all this effort, we need the enterprise data governance. And I had mentioned that on the other screen, data decisions, partnering with our AAs and ADRCs, standards, processes, common framework, all fit into the governance model. So between the technology that we're looking at here and the governance, we'll have the complement we need to move forward in a cohesive fashion to mature data and develop data sharing and exchange at the state level. Next slide. So I had mentioned it briefly on the prior slide. So the state is in the process of pre-planning a statewide customer relationship management system, and it has the term of art called Customers Holistic Aging Relationship Management, which we have a nickname here, CHARM. And it goes along with that rowing in the same boat concept. That's why we have the holistic. We want this to work and we want this to benefit our constituents, our AAAs, and ultimately the aging California population that needs our services and supports. So the general goal here is to develop a single statewide customer relationship management system that supports AAAs and ADRCs, reduce redundant manual systems into a statewide customer relationship management system with the capability to bridge to other systems with real-time data access. In a nutshell, that's what it is. Next slide. So the key benefits of this statewide system would be to make information more accessible, so that we can get the data when we need it and where we need it. We also wanted to look at CHARM to provide us the opportunity to build stronger relationships across all CDA programs and relationships with our AAAs and ADRCs. So partnership, like I had mentioned earlier, is really, really key. And using CHARM to open up new opportunities to exchange and share data. This really helps jumpstart our centralized data repository, and CHARM is a mechanism to help us advance more quickly that direction. Additionally, CHARM will give us some real-time data to identify trends, needs, priorities, and even opportunities to where we can improve and tweak our program to better benefit our aging population. Additionally, streamlining reporting. So CHARM, we have an opportunity to do a little bit more with reporting, look at opportunities to increase self-service, and also have ad hoc reporting. Next slide. I'll just touch on a couple things here. This was covered quite well by Timmy earlier. It's required by the exchange framework is required by legislation, noted AB 133. It's not a technology. Healthcare is the primary required partners. We know CalHHS is providing a data sharing agreement. CDA is looking at that. And we'll leverage as much of that as we can and what we come up with, for instance, for CHARM. CDA's role in the data exchange framework, Mark previously last year provided CalHHS some recommendations primarily around, aging and disability data and making sure equity and diversity demographics are captured as part of the exchange framework. And everything else is pretty much been covered. I'll go to the next slide. Takeaways for the AAAs. The data exchange isn't required at this time. I did check with agency. So that's part of the feedback I have there. The deadlines right now primarily pertain to healthcare. The data exchange framework does not preclude AAAs from exchanging data now, and there's no need to wait for our statewide system. But we are subject to state and federal data requirements. And let us know if we can help broker any kind of data discussions with other state entities. We currently review aggregate data, and the data we collect now is limited to federal and state reporting. Next slide. quick timeline. We are, for our statewide system, we're looking to onboard a vendor in the summer. Around that time, we will like to initiate more intense collaboration with the AAAs regarding charm. Plan out how we want to approach collecting a data inventory, identifying gaps and opportunities at the AAA level, and work with the AAAs to establish data migration plans. And in the fall, we hope to establish a data implementation plan and more guidelines and guidance for AAAs and design our technology. Next. And I'll turn this over to Mark.
And I covered this basically in my intro. I think, you know, if you want to look at our MPA data dashboard, we have provided the link in this slide.
We can put that into the chat for everyone.
Great.
Andrea and Mark, thank you so much. I mean, this is all, I think we're sponges at this point of hearing what it is that you have planned and how this all will interconnect. And also, huge takeaway is that you are raising your hand to help with broker other conversations with other agencies and departments. And we just thank you for that collaborative approach. So this was really helpful. Thank you for the level setting. And we will hold for questions as part of our workshopping. So if you have any questions, please put them into the Q&A. And I think you're going to stay on for our facilitated discussion. So again, thank you. I'm going to bring on Katie Weber now. And Katie is the president and founder of Pop Health Solutions and has been a partner with us at Connecting for Better Health and just really elbow to elbow in planning today's event. And Katie's energy is going to be coming through the screen here as she walks us through more of a level setting and overviews again of AAA's and CalAIM, which is going to be and is really integral to this work. So Katie.
Thank you. Thank you, Mark, Andrea, and Timmy for the great overview of the data exchange framework in the California Department of Aging initiatives as it relates to data exchange for older adults and adults with disabilities. As Michael mentioned, next slide. As Michael mentioned, AAAs have been providing social services to older adults to maintain independence in the community since 1973. The core services have included elder rights to help prevent abuse prevention and ombudsman programs, caregiver programs, nutrition programs, including community congregate meals and meal delivery programs for homebound older adults, health and wellness programs, supportive services, including information assistance, homemaker and chore services, transportation and case management and home modifications, legal services, and many, many more. Next slide. AAAs serve a broad range of customers beyond older adults. Over 85% of our country's AAAs serve consumers that are under the age of 60 with a disability or a chronic illness. 78% of our AAA support caregivers of all ages, and 66% of our AAAs serve veterans of all ages. Next slide, please. Most recently, AAAs have several of our AAAs have expanded their services to serve more older adults and adults with disabilities through healthcare contracts and other partnerships. As you can see, they've been going into contracts around care transitions, home care services, assessments for long-term services and sports eligibility, care coordination, case management, medically tailored meals, evidence-based programs for chronic disease management, fall prevention and mental health, transportation, and many, many more. Recent research by Dr. Amanda Brewster from UC Berkeley has shown that partnerships between area agencies on aging and healthcare organizations has shown to reduce both healthcare use and spending for older adults. These partnerships have been primarily focused around enrollees in Medicaid managed care programs. The authors of the study concluded that as hospitals, healthcare providers, and policymakers search for opportunities to improve the health for high need populations, such as older adults with multiple chronic conditions, our findings suggest that AAA should be considered as a key ally for health organizations. Next slide. CalAIM has created several opportunities for AAAs and other community-based organizations to contract with health plans around social services. This has increased the need for AAAs to improve their data interoperability to exchange data with health plans. Before we start discussing the CalAIM opportunities for AAAs and the data sharing needs of these opportunities, I want to preface this conversation that we are on this journey. We are all learning together. This includes health plans, county organizations, medical providers, HIEs, community-based organizations. And I think the key thing is don't feel like you're alone. We're all learning this together. So our managed Medi-Cal, as you know, is going through a transformation underneath CalAIM, which stands for California Advancing and Innovating Medi-Cal. CalAIM has 3 main goals. First one is identify and manage member risk and need through whole person care approaches. They want to move Medi-Cal to a more consistent and seamless system by reducing complexity, increasing flexibility, and improve. Then what third is to improve quality outcomes, reduce disparities, and drive delivery system transformation and innovation through value-based initiatives, modernization of systems, and payment reform. The first contracting opportunity for AAAs I want to talk about is enhanced care management, which is right under CalAIM. Enhanced care management is a brand new benefit providing high-touch care management for Medicare beneficiaries with the highest needs. In January 2023, 2 additional populations of focus will be added to the ECM benefit that align closely with the populations that AAAs already service. This includes nursing individuals that need nursing facility diversion, which are adults at risk for long-term care institutionalization, who are in the absence of services and supports would otherwise require 90 consecutive days or more in inpatient nursing facility, or nursing facility transition, which is an adult nursing facility of residents who want and with supports are able to transition to the community. The second contracting opportunity under CalAIM has been around community supports, where health plans have an optional set of 14 services that provide beneficiaries that are very much aligned with services that AAAs have been providing for over 50 years in our community. Some of the community supports include medically tailored meals, skilled nursing transition services, home modifications, and non-IHSS personal home care services. Sound very familiar. As you can see, this is where the AAAs have been doing this for years. AAAs can also be a key partner with health plans as they roll out their population health management framework strategy under CalAIM. And we'll go into more detail later in this presentation. The other transformation happening under CalAIM is the dual eligible alignment initiatives. And this is the carve-in of institutional of long-term care to be carved into managed Medi-Cal plans statewide starting January 1st, 2023. This incentivizes health plans to collaborate with community-based organizations to provide alternatives to skilled nursing facilities. Next slide. In order for this transformation to be successful, we have to collaborate and work together to make this successful. The state has provided several different types of resources to help your organization to meet you where you're at on your journey. You will hear from several organizations that have been early adopters on how they currently are utilizing these resources to improve their data interoperability between health plans and community-based organizations. The state is investing nearly $5 billion to build out the business and technical and infrastructure of healthcare and social service providers. Under CalAIM, the state has invested over $2 billion that community-based organizations can apply for to help organizations build out their business and technical infrastructure to contract with health plans. These incentive programs include the Incentive Payment Program, otherwise known as IPP, and the Providing Access and Transformation Health, otherwise known as PATH. And we'll drop some of these links as well to get you more background on these programs. Additional funding that the community-based organizations have access to in some regions is the $1.28 billion for the Housing and Homeless Incentive Program called HIP. Some of their regions are utilizing the HIP funding to build out supportive housing programs for older adults and adults with disabilities. Other funding sources are $50 million for the California Data Exchange Framework, technical assistance, and onboarding organizations onto a qualified health information organization, which we'll hear from some later part of our discussion. And last is a $350 million around population health management services to support the rollout of the CalAIM population health framework. Next slide, please. Starting January 2023, it's coming this January, under CalAIM, health plans are required to roll out a population health management framework, as you see from this diagram. AAAs can be a key partner around the rollout of population health framework. AAAs can support health plans by gathering that member information, including that initial screening data. They also can support the assessment and reassessment of members. Last, they can provide that care management and transitional services when appropriate. Now I'm going to hand it over to Victoria Jump, who is the director of Ventura County Area Agency on Aging, to talk about her experience with contracting with health plans and the barriers and challenges, and also, most importantly, the opportunities.
Thank you, Katie, for that introduction, and I'm excited to be here to share what we're doing locally. So those of you who don't know, we are an agency within the county of Ventura, and really we're charged with the overall responsibility to promote the development and implementation of a coordinated system of care that enables older adults, children, and adults with disabilities and their caregivers to live in a community-based setting. We also advocate for those 60 years of age or older and provide leadership in promoting citizen involvement in the planning process and in the delivery of services. As an agency, we provide a full range of services to include long-term case management, including 2 of the Medi-Cal waiver programs, MSSP and the Home and Community-Based Alternatives Waiver. We provide home-delivered meals, caregiver services, evidence-based programs, personal care, homemaker chore, transportation to medical appointments. We also provide respite and home modifications. Additionally, we are one of the designated aging and disability resource centers as well. Next slide, please. So really our current landscape, where we are now and really how we got here. We do have previous experience with managed care plans. We've contracted for fall prevention care case management. We've provided meals for people of all ages for other health plans. And for us, this has been a 12+ year journey to get to the CalAIM relationship, where we have received referrals from Medicare Advantage plans, ACOs, managed care associations as well. And so having those relationships, and as a AAA already receiving those referrals from them, really made us ready to do this. So for us, we have the CalAIM contract through a county-based hubs and spokes model. So we have a county health system in Ventura County that holds a contract with our plan, and we are a subcontractor. Since last January, we've been providing medically tailored meals for individuals discharged from a hospital in the last 30 days with a diagnosis of congestive heart failure. We are also going to be launching community support starting in January, providing respite, personal care, homemaker service, environmental adaptations, and also the 2 community supports related to the transitions from facilities. We are also rolling out the enhanced care management program for people at risk for institutionalization, and also those in transitioning from the facility to the community starting in January. This coming January. We are fortunate in that all of our discussions about how this is going to work involve data. How we're going to know who is eligible, where the data is going to live, how our doctor's going to know what we're doing. And so one of the discussions early on was that the most efficient thing would be to onboard us as an agency into the health, into a health information exchange. And we essentially now have access to medical records where we are, putting the services that we are providing. Claims for us still have to be submitted via fax to one of our plans, which is, when we're talking about data, this is a huge, area for us that, room for improvement. I'm sure that we're probably not, the only one experiencing this. Everything is happening so quickly that not all of us are at the same place or have the same capabilities. And so, this is one of those areas that we all recognize that it's probably not the most efficient thing to be faxing things in this day and age. And so there is the, the potential opportunity to improve our data interoperability through the data exchange framework between AAA and our healthcare plan. And really all of this has led us to understand that really there needs to be further integration of data. Next slide, please. So in order to start our discussions relating to enhanced care management and community supports with our plan and why partnering with the AAA was a great idea, we had to level set and make sure that really we were speaking the same language and showing the plans that we already had like services in place to really show them, like, lead them to yes for us. And so this is one of the things that a chart that we put together for the plan to show, like, okay, look, this is what we're already doing and how this is, very closely aligned with CalAIM. And so these are some of the different programs that we provide. So we have the MSSP program, funding sources, Medi-Cal, showing that, what the eligibility is, if it's a short-term or a long-term program, and what type of, staffing level we had, which to the plan was important. What level are you using? And so we went through looking at some of the programs and how really, it's aligned closely with the ECM expectation with the CalAIM initiative. Next slide, please. And then we came up with another one for community supports. So for those of you who are on the webinar who are, with a plan, know that AAAs provide very much like services to this community supports. And so the CalAIM service of respite, we have, the family caregiver support program that provides respite. We have the MSSP program that provides respite. We provide, the home and community-based alternative program that provides respite. Different sources of funds maybe, but it's still the same program. And so when we went through, the different community supports, leading them to the why of it would be a great idea to partner with the AAA, it was easy for the plan to understand that, okay, this, we have the experience and the expertise already providing these supports to the community. So we were their natural partner to want to contract with to provide these community supports starting in January, except for the meals, which we already provide. Next slide, please. So really, how do we get to where we are with the contracts, and how do we actually operationalize a contract and receive the referrals needed? And for us, we found that data is critical. You can have a contract, but if you're not exchanging data, you're not getting, people from data mining or some other way, then, it's difficult. And so we established a community supports work group early on. And so involved in the community supports work group, we had our whole our Medi-Cal system there, our behavioral health system, our hospital system, and the plan actually participated in the work group. And we had the discussions, like our goals were to work internally to identify people who are eligible for services, which includes that critical data mining from several sources. And we're faced as county agencies, we don't have systems to talk to each other. We're still based, on an email or, a fax type of referral system. And so how can we identify people and get them to the needed services, the right program at the right time? And that involves the data mining. We had to work through how are we going to do referral arrangements internally. In our situation, when you have several CalAIM enhanced care management programs rolling out at the same time with different county agencies providing the same services or similar services, but the intent of them are slightly different. For example, you have the former whole person care that deals with some of the people coming through that program are going to be older adults at risk for institutionalization. Same thing with the behavioral health programs. So we had to work through a process to determine how are you going to determine who goes where? And that has to do with, exchanging data. We also had to work through the transitions of care. So one of the emphasis on the CalAIM program is supporting those people that are on in-home supportive services and that are, on a waiting list, or they have no provider, and then closing that loop when it's approved. So like, how does that happen if I'm not the administrator of in-home supportive services? So we had to work through what was an acceptable process of exchanging data. And so working through with our group, one, we recognized for enhanced care management that we needed to streamline the eligibility process. And now what we're looking at is when when the referral comes in, we look at what's the presenting issue of the person. So if the person is an older adult that, is at risk for institutionalization, but they're homeless or they're a high utilizer, then we send them to the former whole person care program. Same thing with somebody that may meet the criteria, but has a mental illness, then they need to go to that program. So we've had to work, around the data exchange around those issues. And then we're also working through streamlining the process around community supports and how do you really make sure that there's not a duplication of services. And so our solution really was looking at improving the data interoperability between our agencies. And to do that, we're in the process of creating a data warehouse for at least the county services. And so there has been an application to use PATH funding and also potentially the IPP funding as well. So in closing, really for us as a AAA, we can provide these services. We're willing to provide the services, but having the timely access to the data is critical to be able to provide the services quickly and to avoid that duplication and redundancy. So thank you.
Victoria, I echo what just came in on the chat, which is this presentation with the specific experiences and examples is extremely helpful in grounding this conversation. And I know we could have our whole 2 hours of how you are kind of weaving your way through this and getting to a successful landing spot. One quick question before I have all our panelists jump up. Your community support work group, who's part of that? Could you just give a little bit of
So the
background there?
community, yes, so sure. So the community support work group, we are the plan. So our plan is Gold Coast Health Plan. So they are part of that. They attend, several people from the plan actually attend. We have our human service agency who has the APF, Medi-Cal, all of those eligibility programs. They also attend. We also have our behavioral health department. There's an older adults branch. They have several people that attend. And then we have a county hospital system. And so they have an ambulatory care system as well. And so they have representation as part of that work group in addition to, the AAA.
Fantastic. Well, what a resource. It's again, it's great to be able to take some time and really understand the resources that are available throughout every county, or not every county, but several, right? So let's go through and bring up our partnerships or our partners for the discussion. If you could turn on your recording, or your video, I will welcome Dan Chavez, Anastasia, Elena, Lori Hack. I see everybody. There you all are. Bo, are you on? There you are. Okay, so I think the best way to get us going here is I'm going to just lob out one question. If you could all introduce yourself, your organization, and tell us why data sharing is a high priority for you and the work that you do. Dan, I'm going to hand it to you first.
Thanks, Timmy. Good afternoon, all. Well, that's what a health information organization is all about. That's our mission. That is our heartbeat, our blood flow. Everything we do is about information sharing equitably across the continuum of care, not just clinical information, but the social determinants of health. So it's great to be part of this panel. Who's next, Timmy?
I'm going to hand it to Anastasia.
Hi, good afternoon, everyone. Anastasia Dodson at the California Department of Healthcare Services. And we work on Medi-Cal, but also on Medicare issues, especially for dual eligibles. And data sharing, of course, is important, particularly for people who are dually eligible because they tend to have a large number of chronic conditions. They have worse health outcomes than people who are Medicare only, or than many people who are Medi-Cal only. And we know that because of needing to navigate across both Medicare and Medi-Cal, in and of itself can be complex. And then the many partners that they work with, area agencies on aging can be a great resource, but wanting to connect all of the partners together for dual eligibles. But people who are Medi-Cal only, of course, many of those do have, need social determinants of health, et cetera. So we're happy to participate, and we know that there's many players and happy to, support relationships here.
Thank you for joining the conversation. And Bo Henneman.
Hi, good afternoon. My name is Bo Henneman. I'm the Regional VP of Local Engagement for Anthem Blue Cross. Have spent pretty much the last 3 years of my life wrapped up in CalAIM implementation ever since the first proposal was released by DHCS, and also have oversight of our quality and other local engagement teams at Anthem across the state. So, as you can imagine, between all of those things, data exchange and working at the local community level is really at the core of everything that I do at Anthem. And so this is an extremely relevant conversation for me.
Thank you for joining us. And Anwar Zuhid, I think I pronounced this before, Zwahid, right?
You did it correctly, yes. Hi,
Thank you.
Anwar Zuhid. I'm the Vice President of Long-Term Services and Supports for Partners in Care Foundation. We're a nonprofit founded in 1997. We are a large waiver provider for the State Department of Healthcare Services, along with a large CalAIM providers for the health plans. And we also operate our statewide community care hub services. And why data sharing is important to us? Well, I mean, it's really a key part of our goal to ensure a successful integrated care coordination model with all providers.
Fantastic. Thank you. Thank you again for joining us.
Yeah.
And Lori Hack.
Hello, everyone. Lori Hack, the Interim Executive Director for the California Association of Health Information Exchanges. And our organization was put together back in 2014 with a core group of health information organizations that have been operating for many, many years, working within communities, governed by community boards to help ensure that data is shared among the local community, and then as needed is also shared across the state among providers, payers, and other CBOs. So we're really excited about this timing. We obviously, this is our mission. All of our members have been focused on this for many years. But I think this is really the first time in our history that we've seen the nexus of not only the need from a community basis, but also the technology capability, and then funding focus, and of course, support with our partners in the government agencies.
Thank you, Lori. And Elena, thank you for joining us.
Yeah, no, thank you. So hi, everyone. Elena Kalinowski. I'm the Director of Interoperability and Collective Impact with the Community Information Exchange with 211 San Diego. Ugh, it's a mouthful. I'm also a social worker, and so I believe deeply in the data sharing, because I think when, especially for older adults, being able to age in place and age well and address health needs is inherently tied to the ability to address social needs in a cohesive and collective way in tandem with health needs. And I think that the ability to coordinate care in tandem, but also in a person-centered way that accounts for the realities of unique situations and different types of intersectional vulnerabilities is a huge part of why and how we need to share data. And so the CIE acts as a kind of a local data intermediary, and that's really what we are focused on.
Fantastic, thank you, and some great work that's happening in your neck of the woods. I am also going to welcome back Victoria and Mark and Andrea. Please join the conversation. And I am going to just start the conversation here with a few questions. And then if you would like to raise your hand or join in or ask another question, please do that. Katie, I'll lean on you as well. But I'm going to just start off with some, what are those big rocks? What are the big barriers or challenges that you're seeing with the integration that we've heard of social services and health data, clinical data? I am going to start it out with Anwar, if you would get us kicked off with that.
Sure. Well, I mean, Partners in Care, we use multiple data sharing systems like the HMIS and CHIP, the Collection for Homeless Intervention and Prevention. We also utilize 211, Find Help, Collective Medical. And these platforms really provide an opportunity for providers to collect and exchange data with other community organizations and hospitals, but the data is scattered amongst multiple platforms. What are the barriers we're finding is that we have to go from one system to another, and they're not necessarily all consistent. Some systems have more updated information and the other ones don't. You know, through our community care hub, we do operate a sort of data exchange information through the agreements with various providers and appropriate members, but it's only internal and it's only at the local level through our network of providers, such as hospitals and medical groups and in-home supportive services data. But the issue we're finding is that we can't really necessarily access this information. We have to give access to a contracted provider through a BAA. And if we don't have that established, then we have these IT security issues. The information is still not standard. And when we are unable to provide that access to our system, we have to go through a secured portal or a secured fax. So and although it does provide us some almost real-time notification on access to additional home and community-based services, like information from AAA, CBOs, even Medi-Cal eligibility, it's just not 100% accessible with the network of service providers that we are accustomed to working with at our agency. So, I mean, this really tells me that I wish I had Charm today, and that would definitely help a lot.
Fantastic. Bo, do you want to add to that?
Yeah, I can add a couple points, specific to what we've seen in our CalAIM implementation so far. Although I will point out, because Anwar mentioned fax, secured fax, and I was sitting in a meeting the other day and somebody said something about fax, and somebody else was like, "What are you talking about? This is 2022." I was like, "Yeah, but this is still healthcare, and believe it or not, there's still a lot of reliance on fax, right?" And that's kind of crazy when you think about like this discussion that we're having now and like this really broad data infrastructure that we're trying to build out. And yet on a daily basis, I know that our teams in some cases are still getting information via fax. And so, we've got a long ways to go, I think, to get to kind of the end goal of what we're trying to construct here. But I think from a CalAIM perspective, what we've seen is really in terms of working with local CBOs, we do have contracts in place with a couple of AAAs. This is just a huge shift for everyone. And when we talk about the type of data exchange that's needed, it's pretty broad. And some of the things are just tied into the basic program implementation. So things like submitting referrals or requests for authorizations, submitting data on current services that are being provided outside of what we're paying for out of CalAIM. submitting claims and encounter data. It was some of these services, you know, there are care plans and assessments being developed, and having that data shared back with the plans. You know, these are all basic things that are needed to administer this program. And it's a struggle, right? For a lot of reasons, because, you know, if you're working with a small community-based organization, you've never had to submit this stuff to a managed care plan. And as a managed care plan, like, we've never worked with organizations that didn't have some sort of data infrastructure in place, right? So it's a lot of give and take. I think another challenge is really, you know, having to work across multiple plans. And I'm sure Anwar and others can talk about this. And, you know, I will say, you know, this came up in a conversation with a couple of you yesterday, but, you know, from a health plan perspective, we have really made a lot of effort over the last couple of years to work together and try to align as much as possible and make it easier on the provider community, right? And when I think about, like, all the hours I've spent meeting with the other health plans and chipping away at this, you know, it's like 5 years ago, if you told me we were going to be doing this, I would have said, no way, like, not interested, right? And so from a health plan perspective, it feels like we've broken down a lot of barriers. But then every day I hear from some of our community-based organizations, it's so much different between health plans, and we're really struggling trying to figure this out. So where it feels like we've done a lot, it's obvious that it's not enough, right? And more needs to be done. And that's kind of, to me, that's like the biggest challenge and the barrier right there is that, you know, the knowing that we're putting forth all this effort, and it's not just that collaborative discussion. It's, you know, we've built out detailed guides on data sharing. We've hired staff, practice consultants, provider relations staff that are only focused on these programs to work hands-on with providers. We have weekly office hours where people can call in and get questions answered. You know, we're doing all these things, and it's a tremendous amount of work. And yet a lot of the providers are still struggling, right? And so, you know, I think there's still a lot of work to go on this, but, you know, again, kind of looking back from, you know, the facts to this broader data infrastructure exchange that we're trying to develop, like, that's a journey. It's not going to happen overnight. And what we've seen with CalAIM is it's the same thing. You know, we're slowly chipping away at this, slowly trying to make things better. And right now, you know, to be honest, 11 months into the program, that's still a bit painful for a lot of people, because, you know, at the end of the day, like, while we're chipping away on these things to making it better, we're also trying to make sure that the members are getting the services that they need and make sure that our providers are getting paid. And so, you know, those are some of the things going on. I do see one question here in the chat about IPP Monday. Yes, absolutely. Like, we have given a lot of the CalAIM IPP funds to providers who applied to build up the initial staffing infrastructure, as well as some of the data sharing infrastructure. And I know a lot of our providers are working and have applied to the PATH funds directly from DHCS. So, you know, there is money available, but even with that money, it takes time and it takes a lot of effort to get to a point where we're able to share the data that's needed to administer these programs.
Thank you. Thank you for getting us kicked off. And, you know, how do we pull this all together, align? Great themes. And I see hands up. Dan, did you just take yours down?
Well, I figured you'd call on me, Timmy, so I took it down, so not to be distracting.
Okay, great. And then I'll hand it over to Anastasia.
You bet. So one barrier, right, that I've encountered since my move from San Diego north to Santa Cruz is this barrier, that this government construct between health and human services. And one reason we did such great work in San Diego, which I know Alana could speak to in great detail, is that we didn't have that in San Diego, because San Diego was a super agency, right? And now I moved to Santa Cruz, and I'm struck with a whole new barrier that I wasn't used to navigating. And so that's gotten in the way a little bit. I'm not fully educated on the history and why and the like, but I'm navigating through it in Santa Cruz. But it seems to me one of the greatest barriers that we could remove is this barrier between health and human services, right? And I'm curious to what other panelists think, if they have words of advice for me, because we're really trying hard to do this with all kinds of data types and workflows and doing more integration with social determinants of health. And it is in the way without question. So from my perspective, all being relatively new to Santa Cruz, didn't have that in San Diego, I'm curious to what others think, and I'll take any advice and counsel. Thanks, Timmy.
Great, and I will, I'm gonna ask Victoria to jump in on that a little bit because I think that work group was something that we might be able to zero in on. But Anastasia, I wanted to hand it over to you too.
Or if you want to go to Victoria first, mine's
No, it's good.
maybe,
I
okay.
can keep track of all this.
Okay, so I just wanted to also provide a little more context. Some of you may be fully aware, but if not, just that DHCS, we did, back in March, we released CalAIM data sharing authorization guidance to identify permissible data sharing arrangements. You know, just, again, I don't want to opine on any particular county or situation, but as that guidance is available on our website, and I think it's helpful. It does have use cases, examples. We also have a repository of sample data sharing forms and agreements that's also available on our website. Again, could be a tool. Maybe you've already solved that, but if not, you can look at those. And then the last thing is that we are working on a authorization to share confidential Medi-Cal information. It's the Ask Me kind of acronym. And we're kind of on a pilot process right now. So that is another kind of piece in this puzzle. And then the last piece I want to share is that for DSNPs, which is a type of Medicare Advantage plan, which you know, in some counties more than half, and some counties less, but still close to half statewide of Medicare beneficiaries are enrolled in a Medicare Advantage plan. And for DSNPs, which is again a particular type of Medicare Advantage plan for dual eligibles, we're requiring them to, as part of a contract, they have to implement information sharing requirements, which means, to the point about faxes, when someone is admitted to a skilled nursing facility or to a hospital, they need to make sure that that provider, that information admission is also going to the Medi-Cal plan. And in some ways, okay, yes, that's just from a Medicare plan to a Medi-Cal plan, but that platform, we're requiring them to have an electronic process, not a fax process. So just so you know, we're trying from all different directions to move things toward electronic processes and away from manual processes. But I want to say, just for nursing facilities in particular, that they didn't get the same level of funding as hospitals, and they don't have the same federal requirements as hospitals do have for sort of electronic interoperability requirements. So that's, you know, again, part of the whole picture here. Nursing facilities, they have a little bit further to go, but they're an important partner as well.
Thank you so much. And I see in the chat, our colleagues are putting some links there for references to such great resources. So thank you for that. And I'm going to actually go back then to Victoria. You know, it just strikes me that the AAAs have in some ways solved this a bit, because you've been forced to do that on your 12+ year journey, as you laid out. I was wondering if you could give us some experience. You know, Ventura is one county, but your colleagues too, what you're seeing across the board.
We're seeing, you know, I think, you know, in some places there's a lot of willingness, you know, but you're also encountering, you know, health plans that may have no relationships at all with the AAA, and really, I mean, it has to start somewhere. Because this is an opportunity. We've kind of provided our siloed services, as was stated at the beginning, right? We're a siloed little system, you know, a small but mighty and very, you know, important system, and that we're, you know, intentionally built to provide these services under the Older, you know, Americans Act. And so we've always been here, but I just think that there hasn't been that visibility necessarily in all communities with the plans. And you know, in some cases where, you know, you have the AAA that maybe, you know, is more progressive and wants to try new models and new programs, you have those relationships there. But I guess my suggestion for you, Daniel, is you're, you know, coming into a new situation where, you know, you don't have the super agency, is that you have to start somewhere and know that, you know, the AAAs are willing. And so it may be that you have to be that bridge builder. So, you know, bridge the plan with the AAA and any other community-based organizations that are, you know, that are in the community that want to provide the services. You know, from my experience working with our plan and other plans, you know, Medicare Advantage plans, they, you know, they're busy. Their role is to, you know, pay for these services that they don't want to have to put together a network necessarily. They want something that, you know, somebody to come in and say, here's our network. These are the services that we can provide. You know, I recognize because I can provide all these community supports and ECM, it makes it a lot easier for the plan because then they don't have to go out and, you know, find all these providers and do all these contracts. It's kind of like one contract with the county and we can do all these various services. So what you're finding in your new location is that you may have to help build that bridge and just bring the groups together saying we are, you know, we're here, we want to be willing partners, we want to contract.
And I just think that it almost feels like that the AAA infrastructure across the state, as CalAIM is being rolled out, is a really great place to start because you've already gone through and you have those networks and you can apply them to the population that you're serving today, but that they also could potentially serve additional populations. There's something there that could potentially be an opportunity.
Correct. And
Oops, Victoria, you're muted.
Sorry about
Victoria.
that. So the other thing that we all provide up and down the state is information and referral. So when you're looking at like the system where people can get information, you know, about CalAIM and the benefits, even if the AAA is not the provider, you know, it's still the AAA, there should be some relationship there where people can come to the AAA for information about the services that are available for older adults and people with disabilities in their community. And for our, you know, CDAs rolling out the whole aging and disability resource connection network. And so those, you know, those entities that are, you know, ADRCs are going to be critical too, because you actually may find that you know, there's more coordination of services with those ADRCs. So.
Yeah, and I'm going to throw that back to CDA as well as DHCS. Mark, if you can pull us back to how are you thinking about the AAAs as part of your work, and then also for DHCS?
Yeah, for sure. You know, it's wonderful to hear about Victoria's journey and how she got to the point where she is. And as she mentioned, it's taken her 12 years, right? So it's been absolutely a journey. You know, and speaking with a lot of the different AAAs, and I'm sure Victoria and Michael could talk more about this, is they're all in different states, right? So to enter into these kind of partnerships, it is a lift, right? So there might be, you know, funding you could apply for, you could build up these partnerships, but it's also those internal resources that the AAA requires, whether it's, you know, within the AAA or through a county partnership or partnership with other agencies. I'd imagine it's a lot of relationship building, and then you have to have the resources to actually make it happen. I know over the past couple of years with COVID, our AAAs have just been flooded with just being in a reactive mode, right? Like building up new programs, spending the money, you know, kind of serving more people. So I can see how it's going to be a challenge. We're hoping that, you know, a system like Charm will kind of help lead that way, where now you don't have to update a bunch of individual client relationship management systems, but CDA can help you do that, right, through one management system. So we hope that will make things easier. But I also know sort of like the technological and technical capability of AAAs also differ. So that's where I hope over time CDA can also provide that assistance, where we can help build those bridges, at least the technical bridges, so that those AAAs, like the smaller ones who maybe don't have the resources, we can help move them along. But yeah, I mean, I definitely think there's a path to get there.
And Anastasia.
Yeah, well, in fact, we had a Medicare Advantage roundtable meeting, I think in October. And the topic was people who are kind of near duals, people who are just above the Medi-Cal income limit, and how area agencies on aging can partner with Medicare Advantage plans. It's not just limited to people who are eligible for Medi-Cal. So we're happy to do more to, highlight the resources available through area agencies on aging, and happy to, we can connect more with Mark, CDA or C4A to, keep putting the word out. We have lots of ways that we can reach out to Medicare and Medi-Cal plans. And we can have presentations from you all, so.
Fantastic. Yeah, follow up on that. And Katie. Oh, I think you're on mute.
Sorry, unmuted the wrong one. So yeah, no, I think there's a lot of opportunity, like I said, around partnerships as well. So I think even if for the smaller, AAAs, because I'm working on I'm providing TA to a lot of the AAAs statewide under with C4A. So I think there's a lot of opportunity. Even the partners on this call, we've talked about that as possible ways that we could partner together to provide some of that technical architecture and some of those solutions. So I think that's the other thing is really, I don't know if we want to, I want to pass it over to the HIEs, but I think there's a huge opportunity to really talk about, I know like in Alameda County, what they're doing is some of that technical infrastructure is being provided by the SHE. So like for some of those smaller housing providers, she is like their social health information exchange in Alameda County, but they are providing the infrastructure for the billing and a lot of the infrastructure that would be needed to contract with health plans, because they realize a lot of these CBOs don't have that technical infrastructure. So leveraging these resources across all the partners, leveraging the HIEs, leveraging the health plans, leveraging the regional data hubs in your area, I think there are opportunities to really accelerate this for those smaller organizations. And I think with all these different types of funding sources the state is investing in, there's this opportunity to align around that. And that's why I think it's also with this DXF in play as well. That is the goal of the DXF, is to improve data interoperability between your medical and social providers. So they are providing a structure to be able to do that. So I think that's the key thing, is we are providing the pieces to be able to do that. And I think through these local regional collaborators and also funding, because we've never had funding before, so much funding go to our CBOs. I think this is what we're really excited about, right? Because they don't have to go at risk. The state is investing in those CBOs, so they give them that money to build out the technical architecture, to build out that staffing as well, to be able to do this without them having to go at risk. So I think that's just something to think about.
Okay, great. I see lots of hands raising. So Elena, wonderful. How are you seeing that how are you doing? I mean, you're doing this work.
I just really appreciate, Katie, your point, because I think part of the partnerships kind of drives the use cases for interoperability and buy-in. So I think that's also part of it. So part of why I think that like CDA and the data elements, for instance, that are really a part of the master plan on aging and how it aligns with CalAIM efforts is actually like a really beautiful nexus I think of, so for instance, and I'll just as a level set very quickly, the Community Information Exchange in San Diego is a health and social service legal network sharing data on essentially a longitudinal shared client record, pulling in data from multiple sources that kind of demonstrates both social data as well as some health data, but really also care coordination data elements. Anyway, one of the things that, thank you. That's one of the things that I think is really powerful. And as I work with different older adult service providers, kind of also within a continuum of vulnerabilities. So you've got, older adult service providers that are really focused on older adults that are trying to really age in place but are housed. And you have homeless service providers that are focused often on people, who are experiencing homelessness. And in San Diego, one of our fastest growing populations of people experiencing homelessness are older adults, right? And so one of the things we're trying to get at is, okay, we've got this like delta of missing information that both aligns with the, master plan on aging, CalAIM focus of populations and interventions. And how can we, through partnerships, recognize like, what data are we missing? What data are we trying to collect? And what data are we trying to like have as a community to understand what our needs are? So might that be, social isolation and loneliness as a predictor in terms of, health needs and stable housing, and how that intersects with other needs. And so the slide that was just put up is kind of an example of the types of data that lives on our shared records. But I think the partnerships really do drive what people think about as meaningful interoperability opportunities and those alignments. Because I think like when people talk about how do we make sure we're rowing in the same boat, what does that look like in practice and in action? And I think that's where those partnerships get to drive that.
Agreed. Lori?
Hi, I just want to echo a couple of those comments that Alana and Katie made. What we're seeing, interestingly enough, is not only this community connection where within a county or even within a portion of the county, the stakeholders are gathering together to say, I have this data, I have this connection, we don't have it here. And so I think this opportunity where the state is really putting out resources, funding, and information to connect people better has been really interesting. And seeing what the AAA has as well really feeds into that. I also, with another hat, I'm a trustee for a healthcare district in Calaveras County, very rural, very disparate. And we literally sat together on a Saturday with the heads of the various agencies. And for the first time, I guess, in a couple of years, they spoke about all the needs of the community and didn't realize the resources that were already there that just hadn't been connected. So I think that's where all of this is just really critical, to have that communication, the education, and to be really focused on actual use cases that can be implemented rapidly so that we can learn from each other and then have those continue throughout the state.
To use our technical colleague terms, we need to start sprinting, right? And to solve some of those very specific cases. And I know, Dan, you also have experienced both, really uniquely from coming from San Diego, that has at least started combining social services data with healthcare clinical data and claim data, administrative data, to be able to show that full picture. And yet some communities and many HIEs have not gone down into the social services yet. What are you seeing, and what I don't want to put words in your mouth, so take it away.
Thanks, Timmy. I would really encourage the audience to devote a couple of hours looking at the various HIEs and CIEs in the state. Spend 30 minutes, 60 minutes doing a demo, because they're very powerful tools. And I don't think people realize just how powerful they are until you see them, how they can be configured, how can they be queried at the individual, at the aggregate level. And I think you'll all be incredibly impressed as to the power. And then if you dedicate that power to a demographic or a population like aging, it's limitless as to what information is there, how current it is. I will share with you that many users of Health Information Exchange, because so many of these conditions are temporal, right? And so that real-time information as to where that individual is, what those challenges are, right, is really necessary to have that real-time situation. And then to combine them in the aggregate and that whole person view. I know we talk about it a lot in writing, but to see it in practice is mind-blowing, truly. And then serve up a couple scenarios for your HIE or for your CIE. Ask them to demonstrate how they would do it. And I think you just get out of your legacy system, which you're used to heads down typing in, whether it be Salesforce or the EHR or some other system that's probably very old, or even Excel. And by the way, the HIE and the CIEs are so powerful, they can present your information in Excel if that's all you need, right? We can take faxes, parse the fax, and make that information usable. So just come up with a couple of scenarios to the point. It's so leverageable. It's there. It works. We can deal with identity. I love to use my name, right? Dan, Daniel, Danny, Daniel James, DJ. Figure out, is that one person or five? What have they consented to share? That's all available today on HIEs and CIEs and very navigable. It's not, that's 3 clicks, right? And so if you're not comfortable with an HIE or CIE, they're not all the same. That's unfortunate. I think it was Anwar who just spoke so eloquently about just the variety of systems that you have to go through. But the HIE and CIEs will save you lots of time and effort. Become familiar with them, right? See what's there, see what's missing, see how we move to more data convergence and presentation, specifically to this demographic and to this population on the AAA, right? What information is missing from the HIEs and CIEs that you view? How can it be presented differently, specifically to AAA to enhance the workflows and the use cases and the care provided to this population? It's incredibly powerful. Thanks, Tim.
Anwar, yes, I was just going to call on you on your experience.
I gotta echo everything Daniel said. It is just amazing how quickly we can gather this information in real time or almost real time. But most importantly, how it changes through CalAIM. We started doing this prior to CalAIM, but even more through CalAIM, how quickly we could resolve a person's situation. What used to take about 4 to 6 months is literally taking 2 to 4 weeks to resolve. And that includes hospital discharge, nursing home diversion, and homeless, addressing the housing issue. That used to take us a long time through our non-CalAIM programs, but now we're just working diligently to get that information, meet that person at that one place, and get that resolved through our relationships with housing service providers. And this kind of brings up an old thought that I've had. This is what we try to do with CCI, Coordinated Care Initiative, and it really did not work that well. But this is what CalAIM is all about: real-time information, working with other providers. But imagine having this with a information exchange system throughout the state, and that is just priceless. And that would actually allow us to measure the efficacy of CalAIM and ensure its success.
I want to come back and revisit, but I'm going to go directly to you, but I want to come back and revisit how the data exchange framework could potentially help to connect the different HIEs so that all the HIEs throughout the state are playing in the same sandbox, to be able to give you that view. And it came up on our conversation when we were on our workshop around people experiencing homelessness in LA County, that the counties all need to be able to talk to each other as well, and be able to play in the same sandbox. But I'm going to come back to that, Bo.
Well, I just wanted to add one point to kind of all of this so far, and I think Victoria, you kind of mentioned this, like the need to just reach out and start the partnership conversations, and how everybody's at a different place, and we're seeing this across the state. I mean, like I said, we've got contracts today with some AAAs. We're engaged in some who are looking at kind of that hub model. We're engaged in conversations with some who really just want to do one community support, and we're struggling just because of lack of volume and the lift that it's going to take to do this. But the reality is this is more than just community supports and ECM and CalAIM, right? Like this is about working together for a more truly integrated care delivery system. So even if your interest isn't in being a CalAIM provider and contracting with a health plan, getting engaged and then I agree, like exploring like the different HIE capabilities and really understanding what they are is so critical, because it's all about connecting dots and really understanding, okay, I've got this person in front of me, but who else is engaged with them? What are the opportunities? What are the programs we can connect them to? And I know there was reference to the Alameda sheet, that was developed as part of the whole person care pilot, which we've been engaged in the last 6 years. And even our staff at the health plan were kind of skeptical at first. They're like, oh, this is another system we have to log into. But just logging in and seeing, oh, I can see now that this person's connected to this housing provider and they're engaged with this person in county behavioral health, and like starting to connect those dots, like open the door to a whole different level of care coordination, and broke down a ton of barriers. And so I do think it is a critical thing for everybody, regardless of where you're at. Like, you're ready to full on contract with the health plan, or you have no idea what you're doing at this point. Like, in exploring the opportunities and starting to learn more about it is critical. And I'm excited about the data exchange too, Timmy, because we're spread across 29 counties right now. So we got all the health information exchanges and EMRs and like any potential data feed, HMIS, different with every local continuum of care. We've got so many data sources that I have to worry about right now. Data exchanges, I'm excited.
Great. Well, I just had to change location, so sorry about that. But my power is back. Sorry about that. Love videos. Elena, yeah, do you want to add on to that?
Yeah, just very briefly, I just want to know, with the community information exchange here in San Diego, one of the things that I think sometimes I hear come up in some of the national data standards work and interoperability that I sit on, is I think sometimes CBOs and social service providers are not always talked about as ready to be able to share data from an interoperability lens. And I don't think that's as true as it always is sometimes painted as. In San Diego, we are sharing data through APIs with multiple CBOs who have very sophisticated CRMs, who are HIPAA compliant, are working with data standards on kind of a lot across populations, with health plans, with healthcare providers, and have been doing so for quite some time. And so I do think, kind of to both Dan and Bo's point, is like there's a lot of partnerships and opportunities I think to explore, including these really key social service providers that are really creating this wraparound supportive services framework. And so not to, I think dismiss or rule out how many potential interoperability partners sit inside a more CBO or social service provider framework.
Yeah, I think that's a wonderful point, and actually brings back to Anastasia, thinking from DHCS standpoint, as you roll out these programs, and we heard a little bit about the population health program too, is how are you thinking about collecting the data that you need to be able to make your program successful through this network of information sharing infrastructure, I guess is what we have today.
I'm not sure if that was a question for me or like just an opportunity to comment that, yes, we do want to support the local communication. So the population health management service that we will launch next year is intended not necessarily for DHCS to get a bunch of data and look at it and analyze it, but just as much to support local partners. But I know that, we have many flowers blooming in this field, so it's not necessarily the only approach, but we do think it will be timely, and it will be phased in too. So I don't want to sort of overpromise on what will be available July 2023, but to the extent that there are gaps in local data exchange efforts or local sort of agreements, then that population health management service, I think, can be a great tool, and just, trying to be patient and wait for it to come up.
No, it's terrific. Many assets that we'll be able to we look forward to. Katie.
Yeah, one thing I know it's been touched on, but wanted to further expand on is the type of data that the AAAs and also EC Partners in Care, ECM, is really collecting that valuable data in the home. And I think that is where a lot of the ECM providers are telephonic and not in the home. So really providing the ability to leverage these QHIOs, the data exchange policy, to expand that data that is being collected in the home and get that to the medical providers. Because I know I've been involved in several pilots with key medical providers, and they didn't realize how important that data was until they started realizing that these high utilizers that are coming into their ER, the reason why they keep on coming back is because of their social needs. And that's why I saw so much success in San Diego, right? You have the ability not only to see what care teams or what programs are touching that, but they're also providing alerts. Because that's the other big thing about ECM and outreach, right? If that person's back in the hospital and you're trying to reach that person, right, you're not able to reach that person. But I know, like with Collective Metal and other technologies, but also through the shared record, like I like to call it a shared record, is because you do have this ability to have this valuable information, to have these alerts that are happening so that you can know where that person is. So anyway, I just wanted to kind of expand on that.
It's fantastic. And there's a couple questions coming in from our audience today. And I think Anwar and also Victoria, for both of you, how are you using funds to expand your implementation today? Just to give an example of, how are you prioritizing the use of your funds for data? Anwar?
Okay, I was gonna say Victoria. We are definitely taking advantage of the state resources and the health plan resources to really build capacity and build the infrastructure needed in order to make Calian successful. And that includes building a sophisticated medical record per se for our community supports and enhanced care management services. And just kind of broadening on that and making sure that it captures the data from other sources that we are able to collaborate with. And again, like skilled nursing facilities, homeless service providers, hospitals, and even the information we get from medical groups. We've also upgraded our system so that other entities could actually tap into it in a secured way, in a limited way, so that they don't have access to everybody's records, but rather to a refined portion that is contracted, so that we could actually work together and exchange information in that way. But it's definitely no statewide system that includes a free-for-all. It's good for us and our partners, but it's still in a way limited. But it's quite comprehensive, to Katie's point, where we are collecting this valuable home-based information, non-self-reported. So we know the medications, and they're not bringing brown bags to us. We are able to reconcile that information and address the social determinants, identify the clinical medical needs, and coordinate with the medical team that we are working with. So that's pretty much how we're leveraging those funds right now. And it really helped us become a much stronger provider when it comes to our interventions and our service delivery.
That's fantastic. I'm just, the flashbacks of brown bag days.
Yeah.
And faxing goes hand in hand. So I'm glad we're not doing those anymore. Victoria?
For us, I mean, we've put the ask in, and we're still waiting to know whether or not we receive the PATH funding, which would, everybody has this delay. So we're waiting to see, who gets it, which hopefully it's in January. But we have our whole wish list together. And so we've had numerous, discussions with our data system, the providers, what is capable, what can be built. And really we're looking at, for the AAA side, we're the poor social service providers. And so we don't come to the table with these robust systems and all this money to do stuff. So funding is critical. And so we're looking at what do we collect now? What systems are we using? And can they connect to other systems, really, with the hope to reduce our workload? Because we don't have, a ton of extra people to do redundant, data entry. So we're crossing our fingers and hoping that we receive good results. And then we'll have the dream system built, hopefully.
And Timmy, if I could really quickly add to Victoria's, to the audience, speak with your managed care providers. They are the most amazing resource and so highly motivated to help you get really going with any funding or infrastructure need. For example, IPP funding was not available last year, but we obtained it through HealthNet, actually, who helped us catapult our IT system and infrastructure for CalAIM before January 1st. So that was a great collaborative effort. So your health plans are just amazing resources to tap into.
Yeah, it's that extra motivation that's happening, I think, to be able to help accelerate this work is there, the willingness to work together. So great point. And Dan.
Yeah, just real quick, use all your leverageable assets, just an observation and differences between the two geographies I'm very familiar with. San Diego really utilized 211. And for a variety of reasons, 211 wasn't part of the equation in Santa Cruz. So that's an incredibly leverageable asset. And they're just now joining the Santa Cruz Health Information Organization in Santa Cruz. So to the point that Katie made, and having a lot of this still being telephonic, a tremendously leverageable asset, please use it. They contribute a lot to the equation.
Elena, do you want to expand on that?
Sure. I will say, because, you know, our AAA lives with our county and our aging independent services. And so we are fortunate in that we have like essentially our 211 had a pre-existing relationship, right, with the county of San Diego and including our AAA there within that. And of course, our county tends to have a lot of subcontracting, you know, program delivery systems. So that also creates like kind of some natural networks. And so when we built our community information exchange, we did get to take advantage of the fact that, yes, we do already have some kind of existing, you know, overlap in collaborative partners and just familiarity and trust, right? Because all of this does actually come down to, yes, how can we do this? What can we do? But the actual partnerships and the trust, not only to work together and share data that is in itself requires, you know, yes, legal and technical realities, but it also is a shift in how you do practices, right? And so that also is how do we understand how we are all interacting with a shared client and contributing to the shared record, not understanding that we are interdependent and the success of our outcomes are also interdependent. And so I do think that, you know, there's definitely we were very lucky in what was already existing. However, wherever you are, the building of trust and building partnerships across the spectrum of care, and not just with, I think, like, you know, I think of the directionality of data sharing, right? A lot of times, you know, there's a recognizing that there's care coordination, data sharing happening between social services to and from healthcare services. And so recognizing that is buzzy word as this, an ecosystem, and that recognizing that and really facilitating those partnerships, I think, is how you get to leverage whatever configuration, you know, exists in a community and build it locally and take the shape of what a community is and where we're starting at, right?
Absolutely. And I know we only have a few more minutes. A couple of things I just want to give a shout out to a white paper that was just released from Blue Shield of California Industry Initiatives. And it really did a nice job of, we helped author it. So I will give you that little asterisk, but I think it did a great job be able to demonstrate how health plans can work within the community and capture social service data and be a real resource for communities. So echo that. Lori, I also think that you have this perspective working with all of the HIEs about how local can be. And I was just wondering maybe for this last few minutes about expanding on how do we think about the locality and the localness of data sharing and the need to be able to be flexible.
Yeah, thank you, Timmy. I think for a long time, we thought that there needed to be one path, one standard way to collect and share data. And there really isn't. I think the technology's advanced, the thinking has advanced, and the opportunity to really take this local innovation and really create the opportunity to share locally, but then have some high level learnings, have some things that are standardized, and use those to springboard into other locations across the state. That's really where we've seen this expansion of data. And as Alana has said, and Dan and Bo, data is being shared very richly around the state. We just need to help fill some of the gaps that are the folks that have been left behind, bring those up with us as we advance.
I think that's a great way to close us out. And it's this local innovation, local resources, breaking down those silos, building trust, building partners, starting somewhere, and then look to the state leadership to be able to give us the framework, the guardrails, and sustainable programs and funding to be able to get movement and really good outcomes and better, healthier communities. Does anybody else want to kind of add on there? Katie, I know you and I, what's your final thoughts?
I think you covered it. I mean, I think we just have to really take advantage of this. I mean, we're in an exciting time right now. I mean, we have CalAIM, we have the DXF, we have all this funding. So I think really just aligning these initiatives and have that local innovation and make it all happen and work together to make it happen. I mean, it's huge. I mean, we've never had this before, so I think we should jump on it.
Terrific. And so many new acronyms today for many of us, but also just the recognition of the fantastic work that the AAAs are doing and your partners, and what a resource we have. So let's make use of it. And thank you again for participating today. We will be summarizing the conversation, publishing, and working with you all to be able to make sure we got it right. We will go through all the questions and answers too and make sure that those get answered. Again, thank you and have a great day. Take care.